So welcome everybody. Today we are lucky enough to have Dr. Daniel Caplivski with us today, who will discuss safe travel for cancer survivors. And the description is, for those living with cancer, it can feel like life is put on pause. Plans might get canceled, travel's put on hold. However, does that really have to be the case? So you're joining us with Dr. Daniel Caplivski, the director of the Icahn School of Medicine Travel Medicine Program, and he's going to share about safe travel tips for those living with cancer. Dr. Caplivski's background is that he graduated magna cum laude from Harvard College in 1994 and Yale Medical School in 2000. He completed his postgraduate training in internal medicine and infectious disease at Mount Sinai and joined faculty in 2005. Dr. Caplivski has been selected for a New York Magazine's Best Doctors issue yearly from 2015. In addition, he has been selected for the Castle O'Connelly New York Metro's area's top doctors list annually since 2013. Thank you so much for joining us today. We are incredibly lucky to have you. And the floor is yours.
Well, thanks so much. It's so nice to see you all, and I'm glad to be able to connect with you on a very interesting and fun topic. So I'm going to share my screen and just chat with you a little bit about safe travel for cancer survivors. My particular background is that I am the son of two doctors. My parents were both medical students in Lima, Peru. So there's a little Jewish community that found their way from Eastern Europe to Peru. And so that's where they went to medical school at a place called Cayetano Heredia, which is a wonderful university. And so I would spend, some of my vacations in Peru and learning, a lot about the culture and the language. And some of the time I spent was also with medical students from Peru. And they would learn about a lot of diseases like malaria, dengue, yellow fever in the jungle in the north of Peru in Iquitos. So I later, as an infectious disease fellow, was lucky enough to spend more time there in a course called the Gorgas course. And it's a really terrific, comprehensive course that runs over 9 weeks. And we have a lot of lectures from the local experts at Cayetano, as well as, some from all around the world. So the information I'm sharing with you is kind of related to that course in terms of how we prepare travelers for growing abroad. And it brings together a lot of disciplines between infectious disease as well as pulmonary pathophysiology as you think about high altitude and everything. But I just wanted to walk through some of the preparations that we think about when folks are going abroad to countries where infectious diseases might be more prevalent. So I like to start out with a general outline. We're going to talk a bit about a brief history of vaccines. It's very topical right now. We're going through a weird time in history. So I thought I'd take us back a few centuries to think about how this all started. We'll talk about some of the recent emerging pathogens and outbreak events, COVID-19 being obviously the biggest one in everybody's collective memory, but I'll walk you through some other ones that are also interesting to think about in the context of travel medicine. And then we'll go through some additional travel medicine tips. So we'll go into some specifics about vaccine preventable illness. I'll walk you through which vaccines are live attenuated, which are inactivated, and what all that means. We'll talk about malaria prevention, since malaria is one of these diseases that turns out to be important in many of the tropical countries people visit. And then talk about travelers' diarrhea management, since that's also a very common problem no matter where you go. So this is a picture from history of Edward Jenner, and he's relevant to our conversation because he's probably the physician who saved the most lives in history. This is him working on the smallpox vaccine. So at the time, variolization was a procedure that he himself underwent, in which smallpox was such a deadly disease that sometimes kids were exposed to it in the hopes that if they survived, they would be protected. And this is before the germ theory of disease, before we had ability to culture viruses or really understand the immune system in much detail. But there was an observation that was made that if you survive some of these diseases, you were actually protected. So he made the observation, well, I went through this terrible variolization procedure as a kid. It was, it's very painful and terrible. But isn't there a better way? So he made this observation that many times milkmaids had very fair skin on their face, even if they had some scars on their hands. And what the scarring on their hands is from a virus called cowpox, which is another virus similar to smallpox. And it turns out that if you inoculated some of the material from those cowpox lesions into someone like this boy who was the son of his gardener, if you expose them to smallpox, they were protected. And that was a real history-changing moment for medicine because it really started the vaccine era. And if you think about that term vaccine, it really comes from the Latin root for cow. So now we understand that we're inoculating some material from an animal disease into a human, and we are generating protection. So that ends up being, even at the time, a very controversial thing to do. So there was a lot of back and forth, and a lot of debate. But eventually, the world really came around, and we eradicated smallpox from the planet in the 1970s. So the last known case was in Somalia. There are some laboratory stocks, but no further human transmission of smallpox. A real scourge for millennia. And if you go to London and you visit Kensington Gardens, you can see the statue of Jenner. And so he's still revered as a hero. And yet we still have this great debate about vaccines. And even at the time, there was a lot of controversy about inoculating something from animals into humans, and that somehow we would acquire some of their animal characteristics. So you can see a lot of that debate still raging today. But the next moment I just wanted to highlight for us all in history, and many of you lived this, so I think you'll recognize some of these images. This is Jonas Salk and Albert Sabin. So Jonas Salk was actually a Mount Sinai graduate as well. He spent his internship here, so we have a lovely connection to him. And he and Sabin were also pioneers in the field of vaccinology, and their great contributions were to give us the polio vaccines. So many of you might have been small children like this, either receiving the inoculated injectable version of Salk's vaccine or the oral polio vaccine from Sabin, which was a live attenuated virus. And this is a really interesting moment in history. One of our presidents, FDR, was affected by polio. The March of Dimes, was really a foundation that was um, designed to try to raise funds for polio research. And I'm just going to make a book recommendation because I find history so interesting. But this is a book called Polio, An American Story. And that was written by David Oshinsky, who won the Pulitzer Prize for this book. And he really describes in wonderful detail the rivalry between these two physician scientists. So they both believed that their vaccine was the best. They both were trying to get the community to believe in their vaccines. And the truth is, they both had major contributions, and both of these vaccines are still playing a major role. Um, in the United States, we currently use only the Salk vaccine, the inactivated vaccine. And the reason is that this oral version of the vaccine is a live virus. So live viruses, when they get back into the environment, shed in the stool, they can sometimes revert back to a form that's contagious. So when we talk about polio eradication, which is a goal that's within reach globally, um, there are a lot of advantages to the oral vaccine. It's a lot easier to administer in many developing countries. It has broader range of protection against multiple serotypes of polio, but it sometimes can revert to a more contagious form. So in the United States, we've no longer been using this since we only um, we're seeing vaccine-associated polio cases after the disease was naturally eradicated through transmission through the vaccines. So now, if you're traveling to some developing countries, they still use the oral polio vaccine, and there may be some of that polio vaccine that's detected in wastewater, and some of the polio
No, no, no.
transmission can be related to that vaccine. So sometimes we'll make some recommendations about adult polio boosters, even if you had the childhood versions of the vaccine. Okay, so this was, the 1940s and 50s, and many of you will have memories of that polio outbreak in the United States, New York City. Now, if we fast forward over the last 25 years or so, and I just use that as a marker since I left medical school, these are the list of some of the outbreaks that we faced over the last quarter century. Um, so COVID-19 is the big one, in 2019. But if you go back before that about 20 years, we were actually facing an original coronavirus in the SARS-CoV-1 outbreak of 2002. And that started in southern China. There were some patients who ended up in a hotel in Hong Kong from multiple continents. It was a highly transmissible respiratory virus that probably jumped species from some palm civets. And once it was in humans, it was very highly transmissible. The scale of that outbreak was a lot smaller than what we saw later with SARS-CoV-2. And some of that has to do with the virus itself, some of it with the infection controls measures that were put in place. Um, but it gave us a sort of forewarning of how things could move quickly, with the era of airline travel and people moving across the globe in very short periods of time. We could see transmission events happening internationally very quickly. And recently, we've been talking a lot about the bird flu. So H5N1 has been an issue nowadays. But even back in 2003, there was some concern because some cases were occurring among humans who were exposed to poultry. And a lot of those were, again, in parts of China. But it's been a more global problem now as this particular virus has spread. We're still not seeing direct human-to-human transmission, which is our major concern. But even with local poultry or other animal exposures, we are seeing cases. We did see a big new pandemic event in 2009, and so the thing about influenza, the flu viruses, is that we have human influenza, but there are also animal flus, and they circulate among birds, among cows, among pigs. And if you remember 2009, we called it the swine flu. And that's because this particular virus was a mix of pig virus, bird virus, and human viruses, and it became our new seasonal flu. All right, so every 80 to 100 years, we have a new flu virus that has genetically reassorted itself and now becomes the sort of seasonal flu that we're used to seeing every year. And that's the case with H1N1. We saw some more coronavirus outbreaks, including MERS, which was the Middle Eastern Respiratory Syndrome in 2012, but it was overshadowed by this large Ebola outbreak that happened in 2013 to 2016. Okay, it was the largest one we'd seen on record. It was international, so it was a big deal as well. And then I just highlighted a few other mosquito-borne diseases, one called chikungunya, another one called Zika, and then yellow fever. And I'll get into some more detail about yellow fever and the way that it's spread from different parts of the world, as opposed to where it was previously seen. We've had some further Ebola outbreaks in the Democratic Republic of Congo, smaller virus outbreaks like Nipah virus. Obviously, the big one was COVID-19. And then a couple of other outbreaks worth noting for travelers, because Mpox was a very large outbreak in both the United States and other Western nations, but it's also an ongoing problem in parts of Africa. We're monitoring this avian flu, and I'll talk a little bit about measles since it's a very topical subject now in 2025. So let's just talk a little bit about vaccines. Since there are so many vaccines that are now available to protect us from many different types of diseases, it's helpful to sort of think about them in a few categories when we're talking about travel. So what I've done here is put some of the more exotic vaccines on this column, and then some of the more routine ones in this column. So I've also just highlighted a few ones in red that are live attenuated virus or bacterial vaccines. What that means is that for people to have a compromised immune system, we want to be cautious or avoid vaccines that are live. And yellow fever is usually the one that gets the most attention because it is sometimes required for entry into certain countries. So let's say you want to take a big safari to Kenya and Tanzania. Kenya has the yellow fever virus in circulation. Tanzania really doesn't have many cases for many decades, but they do have the mosquitoes that can transmit this virus. So if you're coming in from Kenya into Tanzania, they're going to want to see proof of the vaccine receipt. And if you're traveling to Ghana, another country that has yellow fever, they actually have a visa requirement that we need to show proof of that yellow fever vaccine with a special card. So obviously, that's an important discussion. We have the vaccine in our travel medicine program, but we need to evaluate each traveler and figure out if it's right for them. And the vaccine is given to children aged 9 months up until adults age 59. And then above age 59, we're just a little more cautious because the immune system can naturally slow down a little bit as we age. And there is a very rare potential serious adverse events from yellow fever vaccine that's on the order of about 1 in 800,000 doses. And those include the virus actually causing liver infection or inflammation, or the virus in the vaccine causing a brain infection. So the good news is that those are rare events, and we can sort of select our patient population carefully to make sure the vaccine's right for you. If you are not a candidate for the vaccine because you're on immunosuppressive therapy, or if you're above age 60 and you prefer not to get it, you can still travel to these countries. And what we do is we have a waiver letter and a waiver section on the yellow fever card that documents that you have a contraindication to get the vaccine. And then what do you do to protect yourself? Well, I'm going to go through some insect prevention measures that are important for both malaria, dengue, and yellow fever. And those include repellents that have 30% DEET, and clothing sprays that have permethrin that can help keep away the mosquitoes that transmit yellow fever. So that's a lot of information about that one vaccine. It's special because it's required for entry into certain countries. Most of these others are recommendations or updates on things that you may have already had. So I'll get into more details about the rest as we go through them individually, but I just wanted to highlight just a few categories of these vaccines.
Would you mind if I interrupt for a second?
Sure, please do.
For people who are unable to take those vaccines, because you mentioned that they are immunosuppressant, would you suggest, like, in terms of, would you recommend that they still go on those types of traveling? Like, where do you fall on that?
Yeah, I'm pretty liberal about wanting people to travel and feel confident about where they're going. So some things that can help are knowing an exact itinerary. A good example is Peru. So Peru is a country of many different climates, regions, altitudes. And, for some people, their itinerary will take them to Lima, maybe Cusco and Machu Picchu, but they're not going to enter into the zone in the Amazon rainforest where there's any yellow fever. So that's a good example of an itinerary where you might consider the vaccine depending on where you're going, but it's certainly not needed if you're going to stick to the coastal cities in the highlands. Other countries have requirements that are more related to places you've been through. So if you go from, let's say, Peru into your next stop might be South Africa. South Africa has a requirement for yellow fever vaccine because you've been in the country of Peru. But in that scenario, it's another setting where if you're only in the highlands, I would recommend just getting the waiver letter and not getting the vaccine if you have an immunocompromising condition. And that immunocompromising condition is also a big category. So for some people, they may have had a kidney transplant or bone marrow transplant, and they're on ongoing immunosuppression. Those are pretty clear-cut indications not to get the vaccine. Some people may have had some treatments with monoclonal antibodies, which are also used in many autoimmune conditions, and that's another category in which we generally avoid the vaccine. Some people have had, maybe a course of steroids like prednisone. And as long as it's been at least 6 months since your last dose, we generally think that that's fine to get the vaccine. So it's sort of an individualized approach, and we sort of chat through where you're going exactly within countries. And even if you're going on a big safari to Kenya, a lot of people are pretty good about their insect prevention measures and feel confident about going even without the yellow fever vaccine, especially shorter duration trips. It's some people are only going for 10 to 12 days, where it's we have some students who are going Peace Corps missions where their risk is a lot higher.
Thank you.
Great. Yeah, and feel free to interrupt anytime. I'm happy to jump in on individual questions because that's often where we get the most bang for our buck.
I
Dylan,
just
I see your hand is up.
could,
Yeah.
How long does the yellow fever vaccine last?
That's a great question too. So it turns out it's now good for life. In the past, yeah, that's news. Because in the past we were giving a booster on the yellow fever vaccine every 10 years. And you may have a yellow fever card at home that says expires 10 years after your last dose. But now we have a lot of data that it's actually a long-term immunity. So if you have an old card like that, we can always give you a new one that says that you're immune for life. All right, so yeah, I was going to get into some more details about each individual one, and that was exactly one of the questions that comes up because yellow fever vaccine is considered now lifetime in its protection. So it's a live attenuated virus. We avoid it in people with immunocompromise, and we use it with caution in patients above age 60, although there's more and more data that people above age 60 are tolerating it really well. And so if you fall in that category and you are going to a country that is proposing some risk of yellow fever, we can still give you the vaccine. Now, where is yellow fever present? So yellow fever maps evolve a little bit over time, but the main areas where we're concerned about it are in the Amazon rainforest. So these are some of the areas of Peru, Brazil, Bolivia. And as you see, the highlands of Peru in the Andes, generally there's no risk. And then there's countries across equatorial Africa where it's present. And there are some in which, like Tanzania, there was some historical transmission, but there's really no active transmission. So if you're just going to Tanzania, for example, and not coming in from Kenya, that's another place where you could go without needing the vaccine. Northern African countries, a lot of people ask about Morocco, Algeria, there's no risk there. And then if you go into Southern Africa, Namibia, Botswana, Zimbabwe, South Africa, Mozambique, Madagascar, all these are places without yellow fever risk, so you could travel there without any problem. Now, a couple of more vaccines that are interesting for travelers include the typhoid vaccines. So typhoid is a disease transmitted by contaminated food and water in developing countries. It's caused by the Salmonella bacteria. And Salmonella in the United States is something we usually think about with undercooked chicken or eggs. But in developing countries, it can really be any food, and it's typically street vendor food that we're most concerned about. So if you're going somewhere, let's say to India or Bangladesh in South Asia, where there's a lot more concern for typhoid, these are a couple of the vaccines that are available. One is called Typhon VI. It's a inactivated vaccine, and we typically expect you to have 2 to 3 years of protection on that one. It's safe for everybody, including people who are on immunocompromising medication. So that's a great option. For those that are interested in longer term immunity, we have a live vaccine version that is an oral pill. You take one every other day for 4 pills. And it's, again, like a little longer immunity, but again, because it's a live bacterial vaccine, we avoid it in folks who are immunocompromising. And some people get a little bit of upset stomach, so some people prefer to get the injectable version. And then we also sometimes run into this with all our vaccines, but vaccine stocks sometimes are depleted, and it's sometimes hard to find this one. So where do we see a lot of typhoid? Again, I was mentioning India, Pakistan, Bangladesh. These are, in South Asia areas where we tend to see higher rates of this bacterial illness. I would say most of the cases, there's less than 10,000, in the United States per year, and mostly among travelers in a group called the VFR. So those that are visiting friends and relatives are at higher risk for typhoid because they're more likely to eat from street vendors and have a little bit less caution about what they're eating in general than if we're, let's say, in that tourist category where we're going to be eating really well-cooked foods, avoiding salads, avoiding pitfalls like fruits washed in local water. Some of those basic food and water precautions go a long way in preventing this as well. And then I'll tell you a little bit about a couple exotic vaccines. One is called Japanese encephalitis. So this is an inactivated vaccine, so it's considered safe for all adults and kids above around age 2. Typically, it's a 2-dose series that we give 4 weeks apart, but we have an accelerated version. You can get 1 dose a week apart from the other, and that works just fine. Typically around 2 to 3 years of protection. And this is relevant if you're going to be in Southeast Asia. So mainly, I would say in countries like rural Thailand, Cambodia, Vietnam. It's a rare disease, so we don't really need it for short stays if you're just going there for a couple of weeks. But if you're going to be there for a little longer or being in very rural parts of these countries, including parts of India, it might be a good consideration for preparation as well. Now, this is an interesting one, chikungunya. It's another virus transmitted by mosquitoes. It's a rare disease, used to be seen mainly in Africa. This name comes from the Swahili dialect to mean bent up with pain. And it's a mosquito-borne virus that's a little bit like dengue. So it's very exciting that we have some vaccine options for this because in the past we would just have the sort of mosquito prevention measures. Um, but it's a live attenuated vaccine, and recently we've seen some reports of neurologic and cardiac side effects among patients above 60. So we're not really administering this vaccine at this time while we're figuring out a little bit more about those side effects. There is an inactivated version that's coming to the US market soon, so it will probably replace this version. But here are some of the places where chikungunya was described originally in parts of Africa, then South Asia and Southeast Asia. And then in 2013, we had a really large outbreak in the Americas, in the Caribbean, Central America, and South America. And it was a little bit of a forewarning of what we were going to see with Zika as well. So what happens is these viruses are introduced into places where there are a lot of mosquitoes, and there is not a lot of local immunity. So the people that are living there just don't have antibodies. So you start seeing high levels of outbreaks when these are introduced. So now it's considered endemic in the Americas as well. And Zika had a similar path. It was initially described in Uganda, made some outbreaks in Southeast Asia and parts of Polynesia. And then once it arrived in the Americas in 2015, it was a very large outbreak that included all of South America, Central America, and here in the US. And you'll remember that this one was a really important one for pregnant women because it was associated with this congenital Zika syndrome. At this time, dengue is a very similar virus. It's one that is transmitted by this same mosquito. It's called Aedes aegypti. And dengue is another one we're very interested in preventing. For now, the main way that we prevent is through insect prevention. So DEET-based repellents on your skin and permethrin for your clothes. There are some vaccines available for dengue in other countries. They're not 100% effective, and there's been some safety concerns. So we're really waiting in the US for a more effective one. But this comes up in the Caribbean too. Yeah, go ahead, Jillian.
Robin, your hand is up.
Oh, yeah, someone's got a hand raised. Yeah.
Couple seconds.
Hi, doctor. I have a question. I came on a little late, so I don't know if you spoke about this. Let's say you're traveling and you're going, what do you
Robin, it's cutting out.
let me get a better place in my apartment. Is this better?
Yes.
Is this better? Okay. If you're traveling and you have your vaccines and you still come down with some sort of a virus, can you suggest sort of a first aid kit to put together to take with us?
Yeah. Fantastic question.
Yeah, of things that we should, bring with us to help combat any of the side effects of any of these viruses.
Absolutely. Yeah. Let me jump to that. Just get out of this presentation and jump right down to something called, let's just see if I put it in here. I think I left out that slide, possibly. All right, I'll just go back and chat a little bit about what to do if you get sick when you're abroad. So one of the antibiotics that we typically prescribe for travelers is something called azithromycin. And azithromycin is a very useful antibiotic because it works against diseases like typhoid, so salmonella, as well as many other causes of bacterial traveler's diarrhea. So traveler's diarrhea is a problem that occurs for a lot of folks when you're abroad. There's a lot of bacteria in the food that we're not used to. We usually try to recommend people to have, drink bottled water, stick to food that's well cooked, and avoid salads because, again, raw vegetables, we're not going to be used to the bacteria that's present there. If it's a fruit you're peeling yourself, that's considered fine. But if it's peeled by you, it's just safer than if it's something that's washed in local water. So, those kind of rules help a lot, but you may still experience some severe diarrhea. And in terms of first aid kits, a couple things that are useful include Imodium. So that's an over-the-counter medicine for diarrhea that's an anti-motility agent, right? So that's fine for mild diarrhea, but it has the side effect that it can constipate you. So that may be an issue for some folks when they travel. That sometimes comes up. The other over-the-counter medicine that's helpful is Pepto-Bismol. So Pepto-Bismol can be used for treatment of traveler's diarrhea. And some people actually do it as a prevention. So they'll take a dose of Pepto-Bismol right before every meal and one before bed. And that can be very effective at preventing traveler's diarrhea as well. So bismuth salts has some coating ability on the GI tract, and they have some antimicrobial activity as well. So those two over-the-counter meds, in addition to the prescription, azithromycin is great for the sort of traveler's diarrhea, GI type problems. Azithromycin also works for respiratory infections. So if you've ever taken a Z-Pak, that's what's in it. It's a good antibacterial antibiotic for respiratory infections. For other types of viruses that are more in the category of influenza, coronaviruses, the common cold type viruses, I think it's always helpful to have your standard acetaminophen, Tylenol, Motrin type of fever medicines, and for aches and pains. I think an antihistamine is useful to have in your travel kit, so whether that's Claritin, Benadryl. Benadryl's a little bit sedating, but it can be very helpful for more severe allergies. That's an excellent thing to keep in your kit. And then some topical creams for itching. So a lot of times you're getting exposed to some mosquitoes or other bugs, and if you bring some the cortisone type creams, those are very useful. And then your basic first aid kit items will have a lot of things like a topical antibiotic, Neosporin, or triple antibiotic creams. They're great for just little cuts and scrapes, along with your typical band-aids and that type of thing. And then a lot of folks when they travel will have some issues with motion sickness, whether that's seasickness, airplane sickness. And some of these are prescriptions, but if you ask your doctor for a scopolamine patch, goes behind the ear, typically used on cruise ships, for example. And then a stronger anti-nausea medicine like Zofran on Dancitron is also very helpful for a lot of folks. So that's, a general list of things that we think about. I'll just add one other thing, because a lot of people are going to high altitude places, and I mentioned Cusco and Machu Picchu. For high altitude, there's a medicine that we prescribe called Diamox, which is a diuretic, so it makes you urinate more frequently, but it also helps you adjust to the high altitude a little faster. So that can be a very useful medicine to have on hand. And the way you start it is basically a day before you get to Cusco, for example. You're taking it twice a day, and then by the third day, you're usually acclimatized to the lower oxygen at high altitude. So great question. So thanks for that. Good to have a travel kit with you.
I also see someone wrote in the chat,
Let's take a look.
Janet shared, she said, travel advice and precautions to take for going on a river cruise to Germany, long plane ride. Any tips for jet lag, time difference, and staying healthy? Thank you.
Absolutely. Yeah. So yeah, for the general approach to Germany and other countries in Europe is that you don't have to exercise any special food and water precautions in Western Europe. However, river cruises and other cruises do have some increased risk for norovirus. And norovirus you'll hear about from time to time is a problem, yes, when you have people in close congregate settings, and it's one that can give you usually a fairly short duration illness, but it can be very difficult to deal with, a lot of nausea, vomiting, and diarrhea. So for those kind of scenarios, it's nice to have, again, that Zofran on Dancitron is a useful sort of anti-nausea medicine, and just good fluid hydration. Most of the time you'll have access to, bottled water. It's important when you're dehydrated to keep up with your electrolytes as well. So Gatorade has a solution that includes basically glucose, sodium, and potassium. You don't have to travel with Gatorade. You can travel with, Amazon sends or will sell you some oral rehydration salt packets, which you can add to water, and they'll include all those things. So glucose, sodium, potassium, and that really helps you to keep hydrated. Same things that are in things like chicken soup. So you need a lot of salt when you're dehydrated in addition to the water. In terms of jet lag, that's a great question too, because a lot of folks are going to Europe or maybe Asia, and there's a big time zone difference there. And there's a few different strategies. On the sort of lower end of the um, side effect spectrum would be things like melatonin. So melatonin is over the counter, and you can use that to help adjust to new time zones. And then we have some stronger sleep aids. One of them is called trazodone. It's an antidepressant at higher doses, but at lower doses, it can be useful for sleep. And then we get up into medicines like Ambien and Lunesta, which are sleep aids that typically have a very limited side effect profile, but some people do have some sort of sleepwalking side effects. So for those, we often recommend people try them at home first to make sure they tolerate it. And then if they do, great. If they work for you, that you can get typically about 8 hours of sleep, which is not going to result in any grogginess. And then some people for flight anxiety and those type of problems will use either a benzodiazepine like lorazepam or Xanax. And those are okay, but they can have some additional side effects in terms of drowsiness, in terms of confusion. So we just have to use those with a little more caution. Terrific.
Thank you.
Great. And then I just wanted to bring up hepatitis because there's several different types of hepatitis and it can get a little confusing what you need when you travel. So the main viral hepatitis types that we think about are A, B, and C. A is one that's transmitted by contaminated food and water, and that's the one that's most relevant to most travelers. Hepatitis B is by body fluid contact, so that's more of an issue if you're going to do some sort of a medical procedure or work or volunteer work. And kids have been vaccinated against Hep B since the late 1980s. Hepatitis A became a routine vaccine for kids since the late 90s. So if you're an adult who didn't work in healthcare, you probably didn't need hepatitis B. So you might not have had that, and you may not have had Hep A. So we're often playing catch up when you're going abroad. There's no vaccine against hepatitis C, but there's a treatment for it now, and most of this is transmitted through body fluids. Great. And most of these protections are for life. So once you get 2 doses of hepatitis A, you should be good for life. Same with B. There was a 3-dose vaccine in the past. Now it's 2 doses. Either of those are generally going to give you long-term immunity. And then I wanted to just chat a little bit about bacterial meningitis. So bacterial meningitis is a problem mainly for college kids. So in the United States, sometimes when kids live in dorms, they're from different parts of the country or the world, and they get together and they're sharing different strains of the meningitis bacteria that's sometimes colonizing the nose, and they can get sick, and we want to prevent that. So it became a routine childhood vaccine over the course of the last 20 years. For adults traveling to parts of the world in the meningitis belt, where they see periodic outbreaks, we'll often recommend a meningitis dose if you've never had one, or perhaps a booster if it's been more than 5 years and you're gonna do some sort of a medical volunteer work in some of these countries across Central Africa. And this is there's a couple different versions of the vaccine now. So the one that most kids get is covering 4 different strains. So there are 4 different strains that are most commonly seen among kids. They're ACY and W135. There's an additional type called meningitis B, which was in the past a problem because it was hard to get it into this vaccine, but we now have options for that as well. So, for certain high-risk groups, they're getting the meningitis B vaccine as well. Less of an issue for travelers because it's more meningitis A in Africa, and that's included in this original vaccine. And now we're seeing additional versions that are going to include all of those into single type of vaccine. So there's a lot of progress in the meningitis front. Now I'll mention a little bit about monkeypox or mpox, because you'll hear about this periodically in outbreaks. We had a big outbreak in 2022 in the United States and Europe that was mainly among men who have sex with men, but some other patient populations as well. It's technically a live virus vaccine, but it's a non-replicating virus that's delivering it, so it's safe even in immunocompromised patients. Would you need this vaccine? Probably not. This was the outbreak in Europe and the US in 2022. The tail end of that outbreak is where we are now, and it's really we're still very rarely seeing some mpox cases domestically. There is some concern because there was some additional mpox happening in parts of Uganda, but it was mainly among the local population, and so for some people who are going to do volunteer missions or healthcare work, we would consider it, but for most people, you wouldn't need it. And then that brings us to measles. So measles in 2015, we had a fairly large outbreak associated with Disneyland. So there was, a group of people visiting Disneyland. They had measles. They didn't know it. And then there's, been declining rates of vaccination of measles going back a long time. And unfortunately, there was a large multi-state outbreak where people were exposed at that theme park. And it's a very highly contagious virus, and that's part of the problem with measles is that if you have someone who's not been immunized and they're together with someone who's got the actual disease, there's a very high chance that they'll be infected. And we saw some further outbreaks here in New York City in 2018, 2019, in Rockland County and parts of Brooklyn among people who are not immunized. And then now here in 2025, we're dealing with a fairly large outbreak, mainly in Texas, but we're seeing cases here in the New York City area as well. So what do we do about measles? Well, the good news is we have a really effective vaccine in MMR. The measles, mumps, rubella vaccine is a live attenuated virus. So what that means is, let me just see if I've got. I was just going to point out a thing or two about live attenuated viruses. It means that we are actually injecting some live virus into someone's body, and it's weakened to the point that it won't cause disease in most people. But in people who are immunocompromised, we have to use it with caution. The other thing to know about measles is it was considered endemic in the United States. And if you're born before 1957, then you are considered immune. Now, there's some questions sometimes people have about, maybe I should get my antibody titers checked. And, if there's an outbreak, I want to know that I'm fully immune. And if not, should I get additional doses of the measles, mumps, rubella vaccine? And generally, the recommendation from CDC is that if your birth date is before 1957, you're considered presumptive immunity. Sometimes during outbreak settings in healthcare workers who are born before 1957, we might consider, checking those serologies or antibody levels and then giving boosters as needed. But if you're in that category of born before 57, you're most likely still immune from the natural infection that was 95% of the population in the US. So these are just some different types of vaccines that are available. And I put them up here because the mRNA vaccines really changed the game once we went through COVID. It changed the ability to rapidly produce vaccines to respond to a lot of these outbreaks. Inactivated virus vaccines are often killed viruses, and those are safe for everybody. Viral vector vaccines are sometimes ways of delivering some of that interesting protein to someone in a way that's delivered in a non-replicating virus, so that mpox vaccine is an example of that. And then we have recombinant protein vaccines like the hepatitis B vaccine, which is basically producing only the protein, not any of the infectious virus particle, and that's often enough to get people immune for a long time.
Can I ask a question? I know
Sure.
something that's come up in our groups is how comfortable, like some of our community can be on, let's say, immunotherapy for a year.
Yeah.
And feel pretty stuck, like that they can't travel for this year, right? And there's so much
Right.
up in the air. What's your thoughts on people traveling, whether they're receiving chemotherapy or immunotherapy?
Yeah, I would say that we do see a lot of these folks, coming through who have had liver transplant, kidney transplant, immunosuppressive therapy for Crohn's disease, cancer chemotherapy, and I think we can generally tailor the pre-travel vaccinations and preparations to each individual, and really go through your itinerary and figure out what are the risks for each individual stop, and most of the time we can get people some good confidence to travel. Even to some tropical countries where some of these diseases are more prevalent. And a lot of it's just, figuring out which of the vaccines are safe and which we should avoid. And then sometimes we add some additional vaccines we might not use in other travelers. And that gets into some of these routine ones like flu vaccine. It's pretty important for everybody to be getting the flu vaccine every season, but especially for those that, who are immunocompromised. And so there are some versions that are higher dose, for example, for those adults above 65. There are some versions that are live attenuated vaccines against flu that we don't use. But yeah, I'd say you should be able to travel. We just sometimes have to do some additional preparations.
And so it sounds like you're in support of people traveling, flying. And
Yeah.
I don't
Oh,
think
yeah,
we're
that's a good
even
question.
talking very exotic. We're not talking
Yeah.
super exotic. We're talking
Right.
just, travel, but not to places that might need
Yeah. No, it's a good
fever
question. Even
vaccine,
like,
but something
mhm.
that's you're in support of that.
Yeah, even like domestic travel. People asked a lot about that during COVID, for example. So
Mhm.
just jumping back to the COVID topic. So like, COVID vaccines, have been very effective. I think if you think back to where we were in late 2020, and once we start getting those first COVID vaccines into people's arms, it was a real game changer. Coronaviruses, globally, this particular coronavirus has slowly drifted a little bit. It's changed a little bit, so we've had to update those vaccines. And people often want to know, should I be getting more COVID boosters, like we were doing every 3 months, for a while when there was a lot of COVID around. I think we're getting to the point probably where we're going to see a once a year COVID vaccine probably in the fall in the Northern Hemisphere. It's politically, obviously, things are up in the air. We don't really know where we're going in a lot of this vaccine preparations. But I would say that the goodness is that with the global population having more and more antibodies, and the fact this coronavirus, that so many people have had the natural infection, that now we're seeing it become a little bit more like a seasonal coronavirus, which means it's like the typical cold and flu ones. That being said, I think the boosters on COVID every 3 months for some people will make sense, or whether that's interval of 6 months or once a year. And I think that we can sort of tailor it to each individual. And the other thing about airline travel, people wonder about, I think, is the air filtration, circulation, mask wearing. I think a lot of that is still relevant for some people who are highly immunocompromised, having gone through cancer chemotherapy, maybe neutropenic. And so, like, I think, for some people, wearing an N95 mask on an airplane, makes sense. It's some comfort for them. It gives them some confidence that even if they're in close contact with a lot of other people, they're lower risk for, picking up a virus, for example. The sort of air filtration that goes through airlines is typically very good. They're passing the air through filters very frequently, so that also can decrease the risk of transmission. Great. So I'll just go through a couple more points.
I'm sorry.
One is um, you could end up being exposed to some of the same things that we see here, in terms of respiratory viruses, or you might just get some sort of a bacterial infection. And then the concern is, well, maybe now you're in a foreign country. How confident do you feel in that healthcare system if you needed to be hospitalized and get antibiotics, for example?
Well, it's
Um,
France. I mean,
yeah,
it's
France, Germany, yeah, they're all very
the
high level.
worry.
Yeah,
Yeah.
very high level healthcare settings. And even places, like Thailand and Bangkok, they're very adept at caring for tourists. They just have a big tourist industry. So a lot of places in the world, you can go and feel pretty confident. Um, but yeah, no, I understand. A lot of oncologists also, I think, feel very protective. Because they're using treatments that immunosuppress you, and they want to make sure you're not going to get sick from things that give you neutropenia or impair your T cells or other things that. So they're very protective, which is a good thing. Um, but I think sometimes you can temper that with the knowledge that, yeah, you're going to a place with high level medical care, and in general, there are some. I'll just mention a few things in Europe that are slightly different. So they have some tick-borne infections, like tick-borne encephalitis, that is not something that we have in the United States. There's technically a vaccine with that you can get in Germany. We don't typically use it here because we don't see many people with that problem. But again, it's a pretty rare disease, and you can use insect prevention measures if you're going to be outside in the forests of Germany, that kind of thing. It's equivalent to what I would think of here as, like, we have West Nile virus. So if someone from Europe is traveling to the US, they might be concerned because the mosquitoes in New York, in Suffolk County might have some West Nile virus reported, but we go about our business not really thinking about that too much. So you can kind of put that in perspective too.
I want to be mindful of your time. I do, because we have 5 more minutes of it. I do see that there was one question from Robin in the chat. She asked, is Novavax as effective as Moderna or Pfizer?
That's a great question too. So yeah, I would say Novavax is a new and interesting version of the vaccine that has come out. And the mRNA vaccines from Pfizer and Moderna are based on a technology in which we're delivering mRNA, which is genetic code for the spike protein. And then that spike protein is going to generate antibody production. And they're generally very effective, but some people had a lot of immune side effects from that, and we're feeling really tired, and there's some significant immunogenicity. Novavax is a viral vector vaccine, which is exciting because it's another way to deliver this material, and the efficacy looks very good. And some people who maybe didn't tolerate these mRNA vaccines might be a good candidate for this viral vector. And it's a non-replicating vector, so again, it would be considered safe even if you have immunocompromising condition. Great. So I'll just wrap up. A lot of these slides are about sort of the routine vaccines, pneumococcus, shingles, all those kind of things. And then I just wanted to give a couple tips on malaria. These are just a couple of cases to talk about malaria. But I mainly wanted to talk about prevention and just show you this interesting cartoon about how malaria is transmitted. So malaria is transmitted by a mosquito that takes its bites at night. So a lot of what we do for malaria prevention is try to prevent that mosquito bite. So whether that's repellents or clothing that's got an insecticide, we're trying to prevent that. But we also often have people take an antimalarial tablet that works at the level of the blood phase of malaria. Malaria parasites go through the liver and then they come out and infect red cells. And most of what our antimalarials do is prevent it from getting bad by treating you at the blood level. But there can be some versions of malaria that do stay behind the liver, and we have some separate treatments for those liver phases. All that to say that we definitely have some good preventative strategies for malaria prophylaxis. Those include insect prevention measures, atovaquone proguanil, which is the Malarone tablets that we use the most of. Very rarely we'll use some doxycycline. It requires you to take it for an extra month after you leave a country that's endemic for malaria. And mefloquine just has a lot of side effects with weird dreams, so we don't use it much either. Primaquine and tafenoquine are mainly these medicines that are used to treat the liver phase of certain species. And chloroquine used to be a great drug for malaria, but there's a lot of resistance out there. So unless you're going to the Caribbean or Central America, you're probably not using that for prevention. And these are just some examples of the mosquito nets that can be treated with permethrin, which is a spray shown here. You spray this on your clothes, your nets, and that really goes a long way to preventing the mosquito bites. The DEET-based repellents like Ultrathon and Benz 30, they give you typically pretty long-lasting protection. So yeah, I just wanted to highlight that there's been a lot of outbreaks that demonstrate the speed at which emerging pathogens can be transmitted globally. Vector-borne illness remains a major public health problem throughout the world, and vaccines represent one of the most important medical innovations in history. So let me stop there, and then take some more questions or hear your thoughts about other things you're planning on traveling and things.
I am thrilled to hear that people are considering traveling. And Janet, about your river cruise, I think that's like how we talked about in the beginning. The goal is to live while going through this or after cancer treatment, and that you're doing it.